All good? I think so. Did you? Okay. Okay, great.
Okay.
Do we have many? Doesn't seem like we have many reporters here. Or are they going to ask questions?
Alex is a reporter.
Mm-hmm.
Channel 2 was sending or channel right there. Channel 2 is right there.
Okay.
Channel 4 is right there. 2-5, and then
Okay.
ours is in the middle.
Okay.
I haven't seen Sarah. She said she was coming, but I haven't seen her yet.
Sure. Okay.
I'll text her.
I just thought like Dan Gray or somebody would be.
Oh no, they couldn't get him free today.
Okay. Okay, we're all good? All right. Okay, good morning and thank you everyone for joining us here for today's in-person briefing. So I know that we've had a few of these in-person briefings throughout the pandemic, and we've done that as we've marked key moments in the pandemic, and this is really one of those moments. So we've been through a lot this past year, really a year that's been like no other, and we've made just incredible progress against the pandemic, especially in these last few months where we've seen hospitalizations come down and we've seen more and more people become fully vaccinated throughout the metropolitan area. But our work isn't done yet. We still have a significant amount of work that needs to be accomplished if we want to save more lives and fully reopen our economy. Unfortunately, we're still seeing people getting sick and being admitted to our hospitals for what is almost entirely a preventable disease. Now, the good news is, though, is that we have more control now than we've ever had in the pandemic in plotting our course forward. But before we talk about where we're heading with the virus, let me tell you about where we stand right now. So first, let's turn to an update on our vaccinations in the region. So as you can see, to date, the vaccinators in our region have administered 1.2 million total doses of COVID vaccines. So that includes around 760,000 first doses and about 500,000 second doses. So all really great news. Again, as I've said in the past, these are conservative numbers because these come from the Show Me Vax data portal. It's a little bit delayed in getting data fed into it. So the way to think about this is a minimum. This is a conservative number on how much vaccine is out there. We know there's more, but you have to wait for those data files to get updated and for the federal data files to get updated. So moving on to admissions. Here we're showing what you've seen throughout the pandemic is a graph of our admissions. So right now we're sitting at 38 admissions, again delayed by 48 hours. And our 7-day rolling average is now at 40. In looking at our hospital census, today we're reporting 220 patients hospitalized with COVID in our task force hospitals. And the moving average is at 212 patients. Now, as you can see over the last couple of months, we've plateaued. And so you can see that we have this really nice decline starting around December and hitting a plateau right around this March time frame. And we really haven't moved much since then. And we're going to talk a little bit about that in the next couple of slides. Our reproductive number, we're sitting right now at about 0.95. And so as we've explained throughout the pandemic, anytime you're above 1, that means you're actively transmitting virus. So you're infecting somebody else. Anytime you're below 1, you've interrupted transmission. And this changes day to day based on the data that we have. And so this is good news that we're below 1. But as you can also see, we've been fairly flat as well in our reproductive number and up into the red and in those yellow areas. And again, we're going to talk about that here in just a moment. Now that rate is dependent upon a couple of different factors, and that's really what's going to set the stage for what we're going to see or some of the things that we can control going forward. A little bit about breakthrough. So this seems to be a very popular phrase right now, breakthrough patients. Many of you have seen the study that came out of the CDC talking about breakthrough patients, things like that. So in looking at our data, I think one thing is very clear, that the vaccines are nearly 100% effective in preventing serious illness and death from the virus. Now, we believe that drop in COVID admissions, which I showed you earlier, is largely because of vaccinations. In looking at our cohort of patients that we have right now, so we took a snapshot earlier this week and said how many patients are in the hospital right now that have been fully vaccinated. And so as you can see, it is a very small number, around 3%. And some of them have been patients that are very sick, so they've had other chronic conditions, so much so that some of them have not been able to build up an immune response. And so even those 7 are not truly there because they weren't protected with vaccine. It was because they're very sick people. So these 3% are breakthrough patients admitted to the hospital, very rare. And looking at this another way, think of all the vaccinations that we've done throughout the region. I just showed you those. 1.2 million doses have been delivered. 500,000 people have been completed their series, and yet we have such a small number of people that are admitted to the hospitals that have been fully vaccinated. I think that really shows you the power of what vaccinations brings in protecting people from becoming seriously ill and having to be admitted to the hospitals. So where could we potentially go? So even as the vaccine continues to roll out across the region, there are a few key challenges standing in the way of really declaring victory in the war against COVID. The first is presence of variants. So we're seeing evidence of really powerful variants of the virus in our community. Those variants are more easily spread and they can make people more sick as well. Now, the second is vaccine hesitancy. Now, to stop the virus from spreading and to get back to a more normal way of life, we really need a substantial percentage of the community vaccinated, the so-called herd immunity. Now, we're making progress towards that goal, so I don't want to forget that, but we're still a long way from reaching that point. Now, new polling data from the Missouri Hospital Association shows that less than half of Missourians who are not already vaccinated plan to get vaccinated. And if that bears out, then it's going to take us a while to reach that herd immunity. And the virus will continue to spread. And we'll be dealing with this pandemic for a long time in the future. And finally, there's that challenge of changing mitigation strategies. Now, there's an understandable temptation to let up on prevention measures, especially because we've seen that considerable drop in cases and in hospitalizations. But for reasons that we're going to outline here, it's too soon to abandon those proven steps that have helped prevent the spread of the virus. Especially when we look at what's going on in the virus in the community. We can look at a couple of data points. So you've heard me talk about this, about a reproductive number, an RE. Now this is an equation that our modelers use, our analytic team uses, to estimate how quickly the virus is spreading out in the community. And I'm going to point out a couple of things for you here, and then we're going to simplify it a little bit so you can understand what are the challenges that we have going forward. So you've heard me talk about this, the reproductive number. It's a calculation, and it's dependent upon a couple of things. So not to get too technical, but this is what's called the R0, the basic reproductive number. And you've heard that a lot in the media, and this is how many people can the virus infect where the other person has not been exposed to the virus. So really it's in what we call a naive population. So nobody is immune. This is how many people it can affect. And then you also have to include what's called the reduction in transmission from control measures. So those are your public health orders, right? Those are limiting sizes or of gatherings or mandatory mask wearing. So you take that into account. And then you take into account how many people are susceptible to the virus, so the proportion of people that are immune. And again, we're going to walk through this here in just a second. So another way to think about it is this. In order to calculate this, we have to know what the underlying virus is doing. We have to see what are the control measures in place, and we have to see how many people are vaccinated within the population. So let's take a look at what happens. This is a very simple way, so this is Dr. Garza's simple cartoon way of doing it. So vaccine times mask times vaccination gives you what is going on out in the community. And we can use that then to predict how many people are going to get sick, how many people are going to end up in the hospital, and unfortunately, how many people are going to die as well. So let's take a look. This is where we are right now. So you have all seen these graphs as we've presented them throughout our press briefings. And this is really somewhat of a best case scenario as well. So what you can see here is where we're sitting right now. So this is number of cases or number of hospitalizations, and this is our plot going out into the future. And the blue box says here, right now we're vaccinating at a certain rate. Right now we have public health control measures in place. And right now, this is what's happening with the virus. This is how much spread is going on. Okay, so again, this is what's going on. Now let's say that something happens to any of these control measures, and then let's plot that out to see what happens into the future. If we increase the variant, so we all know about the circulating UK variant. We all know that this is what is mostly driving the cases up in Michigan, where they have reached the same rate or the same hospitalization rate that they had in the winter. And that's a very scary proposition. We know this is the most common circulating variant the UK is in the country. And we also know it's present here in the St. Louis metropolitan area. And we know that it's more transmissible than the more common circulating coronavirus. So what happens once this takes seed in the community? That means we'll more or less have more cases out there if this gets into the community and starts spreading. And that's really what this green line represents. So this green line here, you can see it's a small bump in cases. It's not too bad. But this also assumes that we're doing public health measures and that we're vaccinating at the same rate that we currently are. So you have to make sure you include those two things. So again, increase in the variant means increase in cases, increase in hospitalizations, so on. Now, what happens if we increase the variant and at the same time relax all of our public health measures? Well, this is what happens. Whenever you increase the variant, of course, there's more transmission. And if you simultaneously then decrease the public health measures, more people will become sick. We'll see more people in the hospital, and unfortunately, more people will die as well. And this is a rather striking curve right here. And so you've seen what happens if we keep everything in place, and this is what happens if we relax public health measures too soon. Interestingly, there's interplay between these two as well. If you relax public health measures, that increases your chance that the variant will spread more rapidly in the community. It just makes sense. If there's less protection out there, the variant is going to spread more quickly. And that's why you end up with this curve looking like this. And this is a scary curve. You can draw the line here and see that it would be equal to about where we were in January, when our hospitals were filled with COVID-19 patients. And nobody, I think I speak for everybody, nobody wants to go back to that. And so the point here is taking these public health measures into account matters when it comes to a number of cases. And then lastly, I want to show one other graph. So if we have an increase in the variant, and by the way, I think it is assumed from all of the epidemiologists and the infectious disease professionals that the variant is going to become the dominant virus in the metropolitan area at some point. It may not be tomorrow, but it's just, we believe, a matter of time before that becomes the dominant virus. It could be now. We have a tough time understanding what the penetration is because we don't do the genetic decoding on every patient that comes in. But eventually it will. And so we will be on one of these curves, we believe, going into the future. So this is the last one I'm going to show you. And so this is, if we have this increase in the variant, like I've said, is the most likely scenario, and we have a decrease in the vaccination rate across the community, then we end up with this purple curve. So this is keeping public health measures in place, but vaccination rates coming down. And so why do I bring that up? Well, across the board, we've seen a decrease in vaccinations, whether it's been in the healthcare systems, our public health partners, or other partners. We've seen a decrease. So as we've said before, we've sort of picked off the low-hanging fruit. It's becoming more challenging now to get people into the clinics to get vaccinated. And so this is the concern, is if the rate continues to decrease where we are right now, that we could end up on this purple line. So let me point out one thing to you about this purple line. I apologize, these are small slides, but we'll get copies to you. Look how far out this extends, down into the fall. So the point being, the faster we can get vaccinated, the lower this slope is, the faster that we can get the pandemic under control. Okay, so you've heard me talk about what are some potential scenarios. These are all models, right? We have a common saying that all models are wrong and some are useful. These are just ways that we can think about how we can plan going into the future based on what we're seeing right now. Nobody is saying that these are absolutely going to happen. There's always other things that play into what the eventual outcome is. But these are the scenarios that we're plotting against those three different things that we can do. Prevent spread from the variant by public health measures and by vaccination. That's how we get the numbers down. And we have to do all three if we want that reproductive number to stay low. That's just the way it works. So before I move on, I just wanted to mention a couple of other things. We've asked a lot of our community and our citizens and our business community over the past year with this goal to save lives and prevent a disaster. And we've been repeatedly asked, when can we go back to normal? And the answer really is not yet. I know everybody wants a date, and unfortunately we can't give you a date. But if we look at a reasonable guess on what would happen if we relax too fast, too soon, we could easily end up right back where we were. Now remember back to that equation, so I'm going to refer back to that equation. We have to be mindful of all of those different things within the equation when we're talking about how fast or how slow can we get back to normal. So that's it on the modeling slide. So now I want to switch focus to what we're seeing right now in our hospitals. And I'm going to ask Dr. Wolf to come up and discuss a little bit about what she's seeing in our patient population every day. So as you saw in some of those numbers, the vast majority of people coming into the hospitals now are unvaccinated. And Dr. Wolf has been taking care of these patients in our hospitals, and she's going to come up and give some testimony about what she's seeing with this patient population now. So, Dr. Wolf?
Hi, everyone. As Dr. Garza mentioned, we very much continue to care for patients with COVID-19 disease in our hospitals. What's different today than a year ago is that the demographic of patients that we're taking care of in the hospital has shifted. A year ago, in the first few months of the pandemic, our patients were largely older, 65, 70 and older, many from nursing homes. Today, the patients that we're taking care of are younger, ages 40 to 64. But just because they're younger, they're no less sick. These are patients who present to us because they develop difficulty breathing. They get winded walking up a flight of stairs. They get winded walking from their sofa to the kitchen. And so they present to our hospitals for care because they can't breathe. And they spend days to weeks with us in the hospital requiring high levels of oxygen support. And the commonality among the patients that we're caring for today is that the majority of them, the vast majority of them, are not yet vaccinated. And when I ask my patients why they're not yet vaccinated, I hear a variety of responses. Sometimes it's that they personally feel that their risk is low and that they're waiting for people in their family or in their community to get the vaccine before them, because to them it felt like, well, if I get COVID, I'm young and I'm relatively healthy and I should do fine. I have another set of patients that have read a lot of the misinformation that's on social media and have become fearful or distrusting of the science, and so they are scared to get the vaccine. And I have a final subset of patients who just think it's not important. You know, they say to me, I don't get a flu shot every year, so why would I get the COVID vaccine? And my response to them is what I will say to you today, which is that if we wish to get to a world that's post-pandemic, if we wish to return to celebrating with family and friends and traveling and enjoying live music and sending our kids to school safely, the safest and fastest way for us to do that is by getting vaccinated. And we are very, very fortunate, I think, in this country and in our region to have COVID vaccine widely available to us. And we are at a point now that the science shows us that these vaccines are safe and they're incredibly effective, as Dr. Garza showed you in the slides. They're nearly 100% effective in preventing severe disease and death from COVID. And so, if I can just recap my comments, what we're seeing is that COVID is very much circulating in our communities, and it is now infecting a younger cohort of patients than it was a year ago. But these patients are just as sick as the patients we cared for a year ago. And we're at a point now in the pandemic where we have vaccine that is widely available. We know that these vaccines are safe and they're effective. And if we want to emerge from this with safer and healthier communities, if we wish to return to life that feels more normal, we have to get vaccinated. It is the only way to keep ourselves and our communities safe. Thank you.
Thank you, Dr. Wolf. So I just want to reiterate what she said. In a pandemic, virtually everyone either gets vaccinated or gets the virus. So in order to avoid all of those other really poor outcomes from occurring, your very best option is to get vaccinated. So we also want to make sure people understand the other risks that are involved with getting COVID itself. So we see a lot of talk about some of the side effects from the vaccine with blood clots. Even though having COVID, you're much more at risk of getting blood clots. And I think most people understand there was really a great paper that came out yesterday from researchers at Washington University talking about some of the long-term issues with having COVID and how common it was. And that was very disturbing, some of the numbers that came out of that study. And so our next speaker, I think, is going to speak to that in more precisely. So right now I want to introduce Dr. Maureen Lyons, who's the director of the Washington University Care and Recovery After COVID-19 Clinic. Dr. Lyons is seeing numerous patients who have had COVID-19 and continue to experience significant symptoms from the virus months after they have cleared the virus itself. So Dr. Lyons, thank you for being here.
Thank you. When I joined faculty at Washington University, my initial roles were clinical and educational. And with COVID, of course, very early on, really by the late spring, it became quite clear that some people who had COVID have symptoms that persist or linger. And so with the support of the Department of Medicine, began working on a clinic to care for these patients. And that was how the Care and Recovery Clinic, or CARE Clinic, began. We've been open now since October of 2020. It's a primary care-based clinic with a network of specialty providers, and together we care for these patients. What we have found are many things, but first is that there's a real need for this. To date, we've seen over about 300 patients and currently have a wait list for new patients. Some of the key trends that we have identified thus far are that the majority of patients that we're seeing did not require hospitalization when they first became ill. Most patients had a relatively mild or moderate course initially. The average age of patients that we're seeing is quite young. Mid-40s is average, with a range mostly between 30s and 60s. Additionally, these are people who were previously quite healthy. They did not have a lot of pre-existing conditions or other medical conditions. In terms of the symptoms, we're seeing I think like many areas of COVID, a very wide variety of symptoms and a spectrum of severity with these. Some of the most common symptoms are fatigue, profound fatigue, brain fog, this inability to concentrate, inability to focus, headaches, chest pain, chest pressure, high heart rates, and really any symptoms that span every organ system. One of the other prominent features that we've seen is a rather profound decline in functional abilities for patients. And that is true both in physical capacity, so patients are not able to do their normal activities at work, at home. This is true cognitively as well. People are not able to think as clearly, work as they had before, manage things in the household. And additionally, changes in mood. New anxiety, depression, and PTSD are unfortunately quite common. The duration of symptoms is unknown, but we have certainly seen patients who have had COVID over a year ago and continue to have symptoms. So, in summary, the impact of COVID, even potentially mild, what seems like mild cases initially, can be quite impactful and can last a long period of time and truthfully an unknown period of time. And the safest way to move forward and to keep yourself safe and keep those around you safe is, as others have mentioned, vaccinations as early as you can, and continued use of other measures such as masks and physical distancing. So thank you. And with that, I will invite Michelle Wilson to speak a little bit more.
Good morning. My name is Michelle Wilson, and I've been recovering from COVID since November 20th. Before the infection, I was a very healthy and active and busy nurse in the perioperative department at BJH. I had no pre-existing conditions, and initially I had a very mild to moderate case. I was actually getting ready to go back to work, excitedly planning for that, and all of a sudden, within a 24-hour period, I got very, very ill again. And I ended up in the hospital for about 3 days. When I came out of the hospital, I was so grateful that I had not had a worse case than I did. However, I still had all these very intense symptoms that I had to deal with. I had shortness of breath, even just sitting on the couch. I got short of breath just walking to the bathroom, having a conversation with someone. I had a racing heartbeat, even just sitting. I felt like I had a washing machine in my chest half of the time. And it worsened when I laid down, such that I had to sleep kind of propped on pillows on the couch to get even 2 to 4 hours of rest at a time. I developed a severe burning pain in my chest area that wrapped around my back and went down my arms. Very difficult control. Nothing really seemed to help. And I had the difficulty concentrating. I had memory problems, and that severe, profound fatigue that was so severe that I'd get up and take a shower and brush my teeth and then have to lay back down and take a nap. Around the latter part of January, I found the COVID care clinic, and I started to improve. But for the last 5 months, my whole life has been about medications and treatments and going to the pulmonologist and the cardiologist and the primary care doctor and the physical therapist and the occupational therapist. And I'm grateful for all those things, and I am improving. But I've had to learn to live with a really chronic, not well understood disease that we are still learning our treatments and our theories for this as we go along. I'm very, very grateful, as I said, that I didn't get sicker, and I'm certainly grateful that I didn't die. But dying is not the only serious outcome of the COVID-19 virus. It's thought that 10 to 30% of all people of all ages who contract the disease will have lingering symptoms for 3 months or more. And many, as Dr. Lyons mentioned, have had this now for over a year. Preventing further COVID infections in our community is of the utmost importance right now. We are so close to getting this virus under control. And it's just extremely important that right now, just for a little while, we stay with this, that we keep wearing our masks, that we get vaccinated as soon as we can, that we social distance, and that we hand wash. It's going to require all of us doing this to get this thing under control. Because what this virus does is truly terrible. And we owe it to our community to make sure that no one else gets sick, no one else suffers, and there's no more heartbreak. Thank you.
Thank you, Michelle, and thank you, Dr. Lyons. Very much appreciate that. So I think what you've heard here are some really powerful stories about what those long-term effects from COVID-19 are. And so let me go back a little bit to some of the reasons where we've heard about not getting vaccinated. And I'm just going to say a couple of words about those. So one is if you're worried about affording vaccine, the vaccine is completely free. You will never be charged for vaccination. Now, some of the healthcare systems have an administrative fee for people with private insurance, just like they would if you got the flu shot or if you had any other vaccination. However, you will never, ever be turned away at a vaccination site if you don't have insurance, and you will be never asked to pay a fee. The vaccine is completely free. So please do not let that be a barrier to going and getting vaccinated. Now, as we've shown you here, the vaccines have been nearly 100% effective. If you're vaccinated, it's very rare that you would end up in the hospital or severely sick. juxtapose that with what the long-term effects of an actual COVID case are. They're very real and they're very significant. Now, eventually, everybody is either going to be vaccinated or they're going to come down with COVID. That's just the way this virus works. Now, you may be an asymptomatic infection, but you may have serious disease as well. The vaccine is safe. It went through all of the requirements for any other vaccine through the FDA. Yes, it was faster, but that was because of the bureaucratic mechanism, not because of the science. That is why. So we've talked about some of those long-term effects from the actual COVID illness. Now, you put that up against a theoretical long-term effect from the vaccine, and you're not even close. The risks from having a long-term effect from actual COVID are much greater than the theoretical risk from vaccine. So please, let's not use that as a reason. So we know we've asked everyone to sacrifice over the past year, and we know how hard it's been. And we've seen the suffering, we've seen the heartache, we've seen the businesses that will never reopen, and the disproportionate impact on our Black and brown community. So the takeaway message that we have here is that there's still hope, though, and we're so very close. And we need to hold on just a little bit longer to snuff out those smoldering embers of the pandemic so it's not going to become a raging wildfire again. And we're getting closer every day. With every person that's vaccinated, we're getting closer to normal. So let me put it to you this way. You've heard me refer to this as a war before. In this war, there's no negotiated end to this conflict. The virus doesn't negotiate. This has to be surrender of the virus. We have to get that far along that there is a surrender. So, in short, the best thing anyone in St. Louis can do to get this region past the pandemic is to get vaccinated and to keep using measures that will help us defeat the virus. None of us wants to be dealing with this any longer than is necessary. And none of us wants to get this very serious virus as well. I think I speak for my colleagues in the medical community. We would, if we never saw another COVID patient in our lives, I think we would be ecstatic. Now, we know that's not going to happen, but that's what our dream is. And St. Louis has done an amazing job with the pandemic. So let's finish the job. Let's get that final push. Let's get people vaccinated. Let's hold on to what we have with our public health measures. And let's get through this pandemic as fast as we can for everybody's well-being. And so that's going to conclude my comments. I'm going to actually ask my partners from the task force to come up here so we can take some questions from the media. So Dr. Campbell from St. Luke's, Dr. Dunnigan, Dr. Akhtar, and then Shafali, Dr. Wolf. Sorry. Any questions from the media?
I got a question, I guess.
Sure.
I guess just for myself, I had COVID in February. I'm waiting to get vaccinated. I've heard so many different things online. If you've had COVID, you're waiting to get vaccinated. When should you get vaccinated after you've had COVID? Should you wait 3 months? Should you get it? Is there a timetable for people that had it that are
Sure.
waiting?
Sure. I think I'm going to turn to virtually everybody up here, except for myself, is an infectious disease doctor. So I'm going to let them answer that.
You sure?
Sure.
Absolutely.
Get the vaccine. We just ask that you're, oh, sure, so sorry. You can, if you've had COVID, we ask that you're no longer infectious, so please wait the 10 days from the onset of symptoms or 10 days from the date of your test if you're asymptomatic, and then it's safe for you to get the vaccine.
So like, they're not, so some people say, oh, wait 3 months. You're saying it's good to go once you.
Yes, we just would like you to not be contagious so that we can protect the people who are providing the vaccine and anyone else you might be in contact with. But it is otherwise safe for you to get the vaccine. Is that fair? Okay.
Absolutely.
All right, I'm going to read this from my
Yeah, so that's a great question. So part of it is the hesitancy, but I think also part of it is on the distribution side, to be fair. Up until now, we've really relied on sort of static locations for our vaccination efforts, so people would come to the vaccine. So now we're thinking of a different model where we go to the people with vaccines. So whether that is with a community group, a church, other organizations, so that we can push vaccine instead of pulling people to us. And so we've been working with our various partners throughout the healthcare systems, as well as public health, various other community leaders, to try and get our arms wrapped around, okay, so how can we go about doing this so it's not so much, because there's other issues. So it's not just about hesitancy, it's about transportation, it's about work schedules, it's about numerous other things. So we're thinking now the name of the game has got to be about convenience and about availability. And so if we can make it convenient for people to get vaccinated, if we can get out into the community, that is going to be how we're going to address some of these issues. There's always going to be a component of people that are just flat out not going to want to get vaccinated, and that's true. And so I don't want to discount that. But I do believe if we can educate, and if we can get out into the communities, if we can make it more widely available, if we can make it convenient for people, that we can get a substantial number of people vaccinated out in the community. And so it's a little bit of a different way of thinking about it than early on, where it was very much, centered around hospitals and clinics.
Dr. Garza, I wonder, what prompted this discussion here today? And my question is, are you concerned that the public is getting soft, that we're kind of letting down our guard?
Short answer, yes. So we've heard a lot, and we get asked these questions quite a bit. When can we go back to normal? So when do we not have to wear masks anymore? When can we have large gatherings? All of those things. And we look at the numbers. And so we were very excited when we saw those numbers just plummeting from January. Very excited. But then we became concerned when they stalled there at March. And they stalled at a high level. So we're still seeing, upper 40s, 50 patients admitted every day. We're still taking care of over 200 patients that are COVID positive in our hospitals. And I'll reemphasize this, what is largely a preventable disease. So the fear is we look at this going forward, and then we see the vaccination numbers coming down. And then you look around the country and you see, okay, other places that have had this happen, what has the result been? And it's been places like Michigan, where the variant has taken hold, where the public health measures have been relaxed, and you've seen the wave that comes along. And absolutely nobody wants that to happen. And so the reason for this is taking all of this into account. We have to be very clear about how we can prevent this from happening. And that is by increasing our vaccination, holding on to the gains that we've got from our public health measures, so that we can prevent any more people from becoming ill, from having those long-term problems, and those are going to be, a challenge going forward. So anything that we can do to prevent that from happening, we think is a good thing. And this is an inflection moment. Kids are getting out of school. People are going about it. The weather's warming up. All of those different things. So it is to reiterate, what are those things that will get us to where we want to go, which is to end this thing. I hope that answers your question.
How are our numbers comparing to numbers in, say, Texas or Florida that have pretty much removed their mandates?
I think, it's, we've looked at the different factors that play into it. So it does depend on what the prevalence of variants in the environment is, and it also depends on vaccination rates and public health measures. Not every state that's completely relaxed has seen the sort of spectacular rise that Michigan has seen, but Missouri has done really well in this regard. It's really in the bottom 10 in terms of the number of new case rates. So we're actually in a pretty good place right now. I think this press conference and this inflection point, as Alex puts it, is to try to bolster people's spirits and realize that we are in a position to do relatively well compared to many other states.
I think a lot Hi, good morning. And so, I think that's a great question. We're getting that more and more often. I'm vaccinated. Why do I need to be wearing my mask? And part of it is that, even if you're vaccinated, you still have a likelihood of transmitting a virus. As the variants start becoming more and more ubiquitous in Missouri, the virus you're transmitting is more likely to affect some of the younger population who hasn't been vaccinated. I think the other difficulty with that question is how do you vet if someone is or is not vaccinated? So if you go to Target, what do you do? Hold up a passport that says I'm vaccinated, I don't need to wear my mask. And so I think logistically right now, because there's so many people who still need to be vaccinated, and because of the variants coming in, we all still need to do our due diligence and abide by mask wearing guidelines and social distancing. So when we get the question is when can we open back up, when can we go back to normal, that's addressed to us, really I think that question is really a question for the community. The community has to help us do their part, get vaccinated, and while we're vaccinating, maintain the social distancing, the masking. And so when the community is able to help us with those regards, we'll be better able to answer that question back to them.
What is our level of visibility to the presence of variants here? What do we know and what don't we know about how prevalent they are in the St. Louis area?
One of the problems with the variants is that we cannot check them in an individual person. You can have some implications depending on what the test has done, but we don't do whole genome sequencing on everything, so that's a problem. One thing that is very nice, though, is that, and Missouri is the lead in this, is wastewater studies, which have been done at the University of Missouri. Really terrific work. And it's now pretty apparent that the UK variant is in the area quite predominantly. And also in the wastewater studies, we have all of the other variants. We've isolated the Brazilian one. We've isolated the South African one. Those two are particularly concerning, as well as the California variant. So the variants are here. There's no question about it. Does that answer the question? Or?
Yeah, thank you.
Okay.
So it's tough to quantify like how many people that is when you're looking at wastewater. So that's the challenge with it. And as Bill said, you don't do whole genome sequencing on every patient that comes in. And so it's tough to know. The PCR test that's used to diagnose COVID isn't specific for the different variants. It just tells you it's the SARS-CoV-2 virus is what it tells you.
When the Johnson & Johnson vaccine got recalled, how did you guys see that impact the interest of the public wanting to get vaccines?
That was certainly an unfortunate setback for that vaccine, but I think there are several points about it. One is it was a testament to the level of monitoring that was going on. So to find a vaccine side effect that might be as infrequent as 1 in a million cases in such a short period of time was pretty amazing. I think every place just stopped using the vaccine briefly till it was all sorted out. What's becoming clear now is that while that's a scary side effect, it's extraordinarily rare, and it's much less common than the same problem that arises in cases of patients who have COVID. So you're at least 10 times as likely to have a cerebral vein thrombosis if you get sick with COVID as you would be to get it from a vaccine. And even that is a little hard to sort out because the coagulation problems, these clotting disorders, have been a big problem with COVID from the beginning. So I think if I were faced with the choice of being unvaccinated and taking Johnson & Johnson, I would have no qualms about being vaccinated with that vaccine.
Just to add a little bit finer point, my family has been vaccinated with the J&J vaccine. So we're confident in the vaccine's effectiveness, and the risk profile is very, very low. Other questions?
Thank you. I kind of have one. If you've had it, is it still important to get vaccinated if your system is immune to it? I mean, I feel like that's something that a lot of people think, if I've already had it, then why would I need to go get the vaccine if my immune system handled it?
Yep. Bill?
Absolutely, yes, for a number of reasons. One, even if you've had the infection, things can kind of wane your antibody levels with time, and whether you would then become susceptible to reinfection is still being looked at. We do know it happens in a few occasions. The thing that's remarkable about the mRNA vaccines, Moderna, Pfizer, and the others, is that they induce an immune response that is extraordinarily high and sustainable, so that it is a quantitative impact that really adds a whole level of security. So people who have the infection should get vaccinated for that very reason. Does that answer the question? Yes.
Okay, any other questions? Yes.
You hinted that there's been sort of a change in demand for the vaccine in the past couple of weeks. Could you give us a sense of what that looks like? Have you seen like a certain percentage decline in signups?
It's actually been fairly dramatic in the high throughput clinics that the health systems have been running. So we've had full clinics up until this week. Pretty much every spot's been taken, and there's been this abrupt decrease in demand. We know that a lot of that demand has been taken up by new access points. So the convention center mass vaccination site, which is very accessible. Many pharmacies in the area now have on-demand COVID vaccine. So what we've seen a fall off in are people pre-registering and making an appointment to be vaccinated. What the overall impact has been on the overall vaccination rate is a little bit hard to tell. As was pointed out earlier, there's a lag in data coming available. There's also some difference in the way federally sponsored programs in the pharmacies and in the convention center process their data. So we don't have an absolutely clear picture of what's happening to overall demand, but we do know there's been a sudden and abrupt decrease in the number of people who are making an appointment to come to one of our clinics.
Thank you.
I was interested in what you said about static vaccination sites versus mobile vaccination sites. And so I'd be interested in anybody talking about the importance of taking down that kind of barrier, I guess, of having to move to a site. I guess, do you think that would make much of a difference when it comes to people who are a little bit not sure about getting the vaccine?
Yeah, so I think people, especially people that are a little bit hesitant, are more comfortable in a familiar surrounding, so outside of a clinic or even a mass vaccination site, to be honest. And if it's people that they know or people that they're familiar with, it probably makes them a little bit more comfortable. So these are all suppositions that I'm making. And so I do think that you're right that eliminating as much, not just physical barriers, but also psychological barriers to getting vaccinated is an important thing. And especially if it's the messenger is somebody that they trust as well. And so it doesn't just have to be a clinician. If it's a pastor or some other community leader that is helping organize and set up and talking to people to come and get vaccinated, I think that's a really important piece as well. And so it's we have to start thinking a little bit differently. Before we were a little bit constrained just because of the amount of vaccine that was available. And to be honest, with one of the vaccines that's currently available has very strict storage requirements, so it makes it even more challenging to get out into the community just because we don't want to waste vaccine either. And so that's why I think the CDC is meeting today to talk about the J&J vaccine, and we do believe that it's going to come back online. And the convenience of that one shot and not the onerous storage capacity that's required from that is really advantageous. And so there's logistics things, but there's also sort of social, cultural, psychological things that are a barrier to vaccination that we have to work on, frankly. Okay. Any other? Yes. Are we good? Okay. Thanks, everybody. Appreciate your time.
Thank you.
Mhm. Yeah, thanks.
Thanks, Alex.
Thanks, guys. Appreciate it.
Good job.
Hey, how are you? Good to see you.
Just want to say welcome and